Oh, Jerry, we can't hear you. Sorry.
So, hello everyone, welcome. Happy New Year, welcome to the fourth, and hopefully that will not the last time that we'll be meeting each other. Fourth webinar for our CELG. So this will be the for now the last webinar and session, and this will be focused on what you have been doing given the grants that were given to you for the implementation of your projects. But first we'll have a presentation of our recap of the last session since it has been 2 months already. So for today, we'll have the recap of the third webinar, which was focused on the proposed strategies and activities based on the lessons that your organizations have learned in each country. And then after our recap, we'll have our presentations from the two countries that haven't presented yet, Philippines and Kenya, and we'll have the regional network summary reports from APCASO and from Africa. And then after that, we'll have a short synthesis, and then we'll have Olive from Global Fund for her to discuss what will be the next steps in our efforts to strengthen our last mile population's capacities to engage in pandemic preparedness and health system strengthening. So just for the recap, we had a context for the programs given by Olive Mamba, and she focused on the Global Fund Pandemic Governance Capacity Building Framework, which discusses what are the next steps and next strategies that Global Fund is focusing on in terms of building the capacities for each country and regional networks in terms of the pandemic preparedness. And then we had the country level projects discussion to strengthen the KVPs and LMPs as offshoots of the CELG assessment and planning process as reviewed by Ms. Rachel Otto Amponsa of ACT Africa. And we had 3 country level presentations from Cambodia, Cameroon, and Mozambique. So from the 3 presentations of the three countries, we found the following common vulnerabilities of our last mile populations, predisposing to the effects of the pandemic on their health status as a population predisposed to TB. One is the increased exposure to infectious diseases based on their occupational hazards, some because of their limited information. Another common vulnerability is the lack of access to health services. One is due to their proximity or the distance from the health facility. One is the lack of permanent living conditions or spaces. And then third is the limited representation in health governance decision-making. Based on these reports, we found out that the pandemic is not only a problem by itself, but it's a multiplier of the vulnerabilities that have already been affecting the vulnerabilities of the last mile populations and the key vulnerable populations. And based on those lessons and characteristics of the KVPC, the presenters suggested the following key strategies to strengthen the KVP and LMP engagements, strengthen engagement strengthening and pandemic proofing health systems. The first is to organize KVPs and LMPs for integrating into existing CSO engagement structures, which were already utilized during the pandemic. The second is to build the capacity of these KVPs and LMPs through pandemic literacy and pandemic governance integration in the organizational processes, such as preparing them for planning, for disaster risk and contingency planning. The third is the facilitation of community-led mobilization advocacy for increasing engagement and participation platforms, particularly in government systems or government platforms. And the fourth is opening platforms for representation and participation in health and pandemic governance structures. So these were the preliminary strategies that were suggested by the presenters in the last session. So for our session now, we will look at what you guys have done, with the project since convening last year. So we'll have before we go to the country projects, we'll go to the regional network summary reports from Asia Pacific and Africa. We'll have Jeff first for Asia Pacific. Do you have questions from the last session, from the recap, before we proceed to the next session, for the next topic? If not, then we can go and we can go to Jeff's presentation.
Thanks, Jerry. Let me just pull in my presentation. Can you see my slide?
Yes.
Yeah, thank you. So good afternoon, everyone from Bangkok. It's nice to see familiar names and familiar faces as well. Happy New Year. I hope you had a wonderful break and a wonderful start of the year. So my presentation for today focuses on the community engagement plans that the 3 countries under the community engagement in pandemic governance project has been supporting in Asia and the Pacific. So that includes Cambodia, Indonesia, and the Philippines. So this presentation summarizes all the different community engagement plans, showing what are the particular similarities and what are the specific interventions that the 3 countries will be implementing, at least for the next 3 years until 2026. So as I've mentioned, we're covering 3 countries from Asia and the Pacific. So this includes Cambodia, Indonesia, and the Philippines. Each of these countries have specific LASMA populations, or TB key and vulnerable populations. And this was a decision that was made in coordination with the Global Fund country team based on the vulnerabilities and risks of these different populations. So you'll see in the slide, for Cambodia, we focus on internal migrants. For Indonesia, we focus on former prisoners. Also, to an extent, those who are still incarcerated. And for the Philippines, we focus on public transportation, specifically tricycle operators and drivers associations. You'll see also the details of their vulnerabilities in the slide. For example, in the Philippines, the tricycle drivers are considered a bridge population, bridging families and also the general public, which makes them highly vulnerable to TB. For Indonesia, being in a closed setting makes them highly vulnerable to TB, and also limited access to health services, including TB services. And then Cambodia as well, the vulnerability at work and the working condition, and also the low knowledge makes them highly vulnerable to tuberculosis. Again, within the CELG project, we use TB as an entry point to understand how these last mile populations have been engaged or are currently engaging in the pandemic response at the country level. So for Cambodia, I only received, and this is also to acknowledge Chantorn was also in the room, the work plan. I wasn't able to include it in the list in this presentation at the moment. But if Chantorn can later share in the open forum. But as far as the priorities is concerned, based on the results of the community engagement assessment report that has been conducted prior to the development of this community engagement plan, here are some of the priorities that has transpired in the report itself. So some of the findings include a listing of the different enriched populations. So within this bulk of internal migrants, we see migrant construction workers, garment workers, people working with painting substances. In these situations and conditions make them vulnerable to tuberculosis and the specific vulnerabilities as well in these conditions. Apart from the working condition, the working environment, the policies within these environments, and limited access to these services also make them highly vulnerable, and inability to actually respond to TB if they ever were exposed to tuberculosis. Within this report, it was also found the need to and the continuing strengthening and expanding of existing community-led networks. Mainly, for example, the district level network of people with TB and TB survivors that has already been established. But at the same time, there's an expressed need to continue strengthening and expanding these community-led networks across other provinces in Cambodia. The last is not the least, corollary or aligned or happening comprehensively at the same time and in parallel with the strengthening of community networks is also the provision of incentives, which is equally important, especially for TB survivors who are just trying to return back to their respective work. This needs to be provided, and also structural issues such as stigma and discrimination has to be addressed at the same time. For Indonesia, what Indonesia did is not a national engagement plan, although it so happened because Jakarta is one of the provinces, a national level priorities of activities have been included. But the approach has been at the provincial level, namely Bali, West Java, and BPI Jakarta. In terms of the priorities based on the engagement plans that they've developed, we see some of common priorities, although this is not exhaustive. The first is the need to increase case discovery, building capacity to identify new cases, provide more outreach, and provide immediate linkage to care, as well as follow-up from former prisoners, supporting current prisoners or those who are currently incarcerated, and link them immediately to TB services. The second priority involves around improving the compliance of prisoners. While it is assumed that prisoners are being monitored and observed in terms of accessing and undertaking TB services, some have really dropped out of compliance. So how do we make sure that once we enroll a particular prisoner who's exposed to TB, that their treatment will be ongoing? And also the post-release aspect of it as well. There's an expressed need to continue accessing healthcare post-release and as they return back to their communities. At the same time, also increasing the education outside of the prison by also provision of the referral letters and accompanying them in person to the nearest facility once they are out of the prison. The third, it's not common, but I'd like to highlight it here, that one of the interventions that's been raised, I think this is in Bali, is the need to provide a mental health care services and support, psychological support to those who are already outside of the prison. There's an increased need to access psychosocial care after they have been released, and at the moment there's a very low access to available mental health care services. For the Philippines, so as you can see in the slide, they're covering 3 years, and they've categorized their different activities based on the communication need, the capacity need, the partnership need, leadership needs, and also the policy development needs that need to be undertaken during this next 3 years. Some of the activities that they identified, which is also common to other countries, is the capacity building awareness around pandemics and around tuberculosis. But what we see in the Philippines is there's a need to have a continuous orientation and awareness, especially on a rolling basis. This is particularly for those who will be participating newly as part of the Tricycle Operators and Drivers Associations as new members, and also for the local government unit as well. There's also an express need to provide support in terms of providing information on how to address stigma and discrimination. In terms of capacity, one of the things that was highlighted in their community engagement plan is the leadership training. This is quite similar also to some other long-term community strengthening that we've conducted under the Global Fund, wherein there's a need for TB survivors to have a more longer-term continued level of support and strengthening advocacy, strengthening leadership, strengthening their participation in different decision-making tables. So this was also expressed in this engagement plan. In terms of partnership, they've identified a number of partners, and they've also identified a number of meetings that needs to be undertaken in order to strengthen their partnership and strengthen their participation in these different decision-making meetings and convenings. And then in terms of leadership and policy development, they've identified some specific areas that needs to improve, such as social protection and also securing income source, especially in a time of a pandemic for tricycle drivers and operators. So in terms of next step, 2 of the 3 countries have already started implementing some of their engagement plans, particularly Indonesia and in the Philippines. And as I mentioned, one of the things that's really the three countries really highlighted is to build information on pandemics. So if you remember our first lessons webinar on a pandemic 101, a similar kind of approach needs to be undertaken as well. But in particular, at the country level, they need to link it to the existing tuberculosis or universal healthcare system or structure to make it more relevant and easier for the government also to absorb. There's also a need to address structural issues, namely stigma and discrimination, social protection, and the social mobilization as part of community system strengthening, which is part of a broader health system strengthening as well. And last but not the least, one of the things that we've observed for Asia and the Pacific is that there will be no new platforms that will be built specific to pandemic response. Instead, they're capitalizing on non-health platforms, which is the GRIA Abipraya for Indonesia. This is a platform for prisoners and ex-prisoners or partnerships that are being established. For example, a memorandum of understanding between the tricycle operators and drivers and the local government units. These are not new platforms, and these are not specific platforms to PPPR. So that's the end of my presentation. I'll be happy to respond to any questions. Thank you. Over to you, Jerry.
Thank you, Jeff. I have several questions just to clarify and just to get some details for us to understand better some of the responses, but it might be better after if I ask them after the countries present. We'll have we'll have Rachel to present. Rachel, are you ready to present after Jeff?
Yes, I'm ready, Jerry. Happy New Year, everyone.
Happy New Year.
If you can pull up my slides for me, Jerry. I hope everyone can hear me.
Yep.
And so for the benefit of those joining us for the first time, this is Community Engagement in Leadership in Pandemic Governance, CELG for short. So there was an assessment conducted for Africa, ACT Africa worked with 5 countries. We worked with Nigeria. Okay. Next slide, please. So ACT Africa worked with 5 African countries. We worked with Nigeria, Cameroon, Mozambique, Kenya, and Sierra Leone. So the assessments were conducted in each of these countries. Next slide. For Nigeria, Nigeria worked with internally displaced people and then nomads. Nigeria worked across 3 northeastern Nigerian states, that is Adamawa, Taraba, and Yobe. And this is basically because IDPs and nomads are vulnerable to TBs and other pandemics. Next slide. So Nigeria has produced a provisional engagement plan. It is yet to send me the final engagement plan. But based on their provisional engagement plan, these are the priorities that, sorry, let me move this, okay. So these are the priorities. First of all, to have an in-person pandemic preparedness training across the 3 states for the leaders of the TB KVPs or the LMPs. And these trained leaders will attend the state level coordination meetings and hold consultations with their constituencies to provide feedback and also facilitate linkage between these TB KVP reps on TB COVID-19 and PPR platform, and eventually on CCMTB constituency reps, state TB network representatives. So basically the whole idea is to get the communities onto the CCMTB constituency platform and then the national platform. And then these KVP leaders will come back to their constituencies and then provide leadership training on advocacies and other relevant skill gaps from their experiences to the people in their constituencies. Next slide. So Cameroon also worked on internally displaced persons because these people are also very vulnerable to TB and other pandemics. Cameroon worked in 3 regions as well. Next slide. Cameroon has a final engagement plan, and these are their priorities. Basically, similarities across all the African regions show that there was a gap in knowledge about TB and then pandemics, and also limited access to health services. And so across all the 3 regions, I realized that there was lack of knowledge on TB and pandemics. So Cameroon's priority is, first of all, to produce image boxes, flyers, and other communications support adapted to target in order to allow them to access adequate information. So basically to provide information for this last mile population, and also develop a new feature of the One Impact tool to take into account community feedbacks from IDPs, and then strengthen the capacities of leaders of IDPs organization on the One Impact approach, and establish a pool of trainers within the IDP organizations, and produce guides on leadership, communication, and advocacy, and also update information on the different governance platforms and activities on TB, COVID-19, and PPR by analyzing the representations of IDP in these different bodies. So as you can see, these priorities are not too different from that of Nigeria. Next slide, please. Mozambique worked with minus and X minus. And the study was also conducted at Majagazi, Gaza province. Based on, Mozambique is still developing its engagement plan, but based on the findings and the recommendation, these are the priorities. The need for continuous education and awareness on TB and pandemic preparedness to reach the unreached LMPs, and then a community-driven initiative where locals are empowered to take active role in initiatives related to TB and pandemic preparedness. And then finally, to introduce incentive for active community participation. Next slide. Sierra Leone worked with people with disabilities, basically because these people are very vulnerable to TB and other pandemics. The engagement plan for Sierra Leone is pending, and the priorities also, as already stated, includes inclusive communication to ensure that TB and pandemic preparedness information is out there, and then capacity building to local health systems and community engagement. Next slide, please. Kenya worked with people with disability as well. Kenya is going to do their presentation after mine, and then these are their engagement plan is still ongoing. These are their priorities: leadership training, community workshops, and then information sharing on pandemic preparedness. Next slide. So basically, the summary is that there's a need for information sharing on pandemics, and then there's a need for strengthening healthcare system through preventive care and education. The next step is implementation of the engagement plans. Next slide. Thank you.
Thank you, Rachel, for the presentation, for the overview for the Africa projects. We'll now go to the specific country projects that have been implemented or have started on implementing. We'll have first the Philippines, represented by Florita Dalida from the organization Achieve. Florita, are you available now?
Yes, Doc. Good evening.
Good evening po.
Good evening to everyone.
Will I be projecting or kayo na po?
Please project the slides,
Okay,
please. Thank you.
Let me see for... Okay. Are you present? Did you do it? Thank you. Yeah.
Okay. I'm Flor Dalida, the project coordinator for CELG project in the Philippines. So I think this is not the first slide. I would like to introduce Achieve. Achieve is located in the Philippines, Quezon City, Philippines, and was founded in the year 2000 with a mission to work with the key and vulnerable communities, empower the stakeholders and policymakers to address public health, migration, and development concerns through evidence-based, human rights-centered, and gender transformative interventions. And using rights-based, gender transformative, and participatory approaches, Achieve endeavors to directly involve communities in the planning, implementation, monitoring, and evaluation of HIV and TB initiatives. Next slide, please. So these are our programs and projects: HIV and AIDS, tuberculosis, migration and health, sexual and reproductive health. So Achieve Inc. was able to establish the Philippine Alliance to Stop TB through the TB project funded by the USAID. So now we are also handling CELG project by APCASO. Next slide, please. So CELG project in the Philippines, these are the challenges and related insights that we encountered during our first quarters of handling the project. First, the survey and mapping tools were not user-friendly. Of course, we will be able to identify those challenges once we do the actual survey in the community. So what we did was we grouped the questions and removed duplicates, and also rephrased the questions and translated in Filipino for better comprehension. And also there is a lack of awareness of the Tricycle Operators and Drivers Association respondents on institutions, structures, and mechanisms in the Philippines. And most of the TODA members interviewed do not know of their group's description despite of the efforts of the interviewer to explain the question and translate it into simple words. Maybe we can also provide synchronized definition of terms for the words used in this study. Next po. So community engagement across identified aspects, the information, consultation, collaboration, empowerment, and participation was poor. Actually, they do not really know that they are entitled to certain health benefits, and they do not appreciate that some of the TODAs actually have their offices within the compounds of an RH or rural health facility, but they do not access health services. So the health-seeking behavior must also be improved. The officers and members of the target group were difficult to engage in the project. They were very hesitant, and they feel that the project is not really pushing through because this is the first time that they were engaged in health related projects. So our related insights, we will enhance awareness, engagement, and empowerment among members of TODAS in Quezon City by conducting 1, regular consultations, 2, collaboration with the stakeholders, 3, empowering members through training and capacity building, and 4, active participation in community leadership and decision-making process. Personally invite them and call them and make them realize that this project aims to improve their quality of life and that their inputs matter. So some of the TODA members appreciates what we are doing. Some of those who were able to attend the consultation meetings, they were able to appreciate how sincere this project to make their lives better. Next slide. Brief description of GF effort to strengthen capacity of KBPs and LMPs. Our objectives of the project is to develop a scalable community engagement model based on COVID-19 and pandemic preparedness and response, and to enhance health-seeking behavior of the TODA community by overcoming health barriers, and to examine the intersection between health interventions and transportation regulation. Next po. Interventions included in the timeline. So we conducted meeting with the members of the TODA community to inform them about CELG project, where they are the subject of the research study. So initially, there was a poor response from the president of the TODA Federation. Other officers and members were willing to participate, but could not fully submit themselves to the project because they are waiting for their president to notify them. So what we did with this is we coordinated with the Tricycle Regulation Division, and the officer of the TRD is very willing to assist us and introduce the project to other TODA leaders. So with the snowballing, there were very limited recommendations from the participants. And this is in relation to the limited or very poor knowledge of the TODA community in acknowledging agencies or partners who could help them elevate their quality of health. Next po. Next slide, please. Next intervention is to conduct capacity building to empower TODA members to participate in decision-making processes. So they already have ideas what they want during the consultation meetings. And our next step is to help them achieve what they want by increasing their awareness on TB and tickling their interest in their right to health. So that is one of our targets to help them realize that they have the right to demand for their for a good health services. And TODA members who participated in the series of meetings and discussions expressed their willingness to participate in capacity building activities. So we already gathered some participants who are willing to be engaged and to be and willing to be trained to help other TODAs became aware of TB and other diseases. Next slide po. So preliminary lessons and next steps. We will collate the plans and recommendations by the participants, particularly focusing on how TODAs can be meaningfully engaged in the process. The plan will include suggested partnership meetings of TODAs with Tricycle Regulation Division, City Health Office for the conduct of TB 101, integrated TB COVID-19 activities, and review of ordinances or policies related to TODAs. Consult with the stakeholders before finalizing and implementing the plan. So that's all. Thank you.
Thank you, Florita. Well, I reserve the questions for after after Kenya's presentation. Jeff, can you make Charles, is it Charles Wanga a presenter?
Yes, Charles Wanga from Kenya.
Hello, we'll have Charles Wanga from Kenya to present their country's project. Welcome, Charles. Are you there, Charles?
Hello, are you able to hear me?
Yes, we are.
And can you see my presentation?
Yeah.
Okay, sure. Yeah, so we are going to look at the community engagement plans in Kenya and of course look at the various interventions that were deployed and also what are some of the proposed activities for engagement plans in the coming months. So this is just the TB situation in Kenya. quite a number of people. If you can see the numbers there from the Ministry of Health and also the National Bureau of Statistics, as well as bodies such as World Bank and World Health Organization. So, TB is the largest cause of death here in Kenya. And, the target proposed is a 90% reduction in TB deaths and an 80% reduction of new cases by 2030. So a lot of initiatives are going on by the government and also other key stakeholders, mostly the non-governmental organization side, to ensure that these targets are achieved here in Kenya. I'll also quickly go through the main findings. And what we did was a series of key informant interviews or expert interviews with key stakeholders working with the people living with disabilities. These included also, TB champions, officials from Kenya Union of the Blind, organizations such as AMREF, Pamoja TB, Ministry of Health officials who are government officials. This was just for the key informant interviews. We also got a chance to speak to some of the doctors who were actually included in the task force to combat COVID-19 and also TB during the time of the pandemic. We also held 14 focus group discussions in the counties of Nairobi and metropolis counties of Kiambu and Machakos. So these are nearby counties in they are nearby, and we spoke to quite a number of the people living with disability. So when we say people living with disability, these include the visually impaired, those who are paralyzed or had any form of paralysis in the body, those who lacked limbs, those who had weakened bodies due to accidents, and also we had participants or discussants who had stunted growth. So those are the myriad of people living with disability who we got an opportunity to actually engage with in the focus group discussions. These are some of the country profiles, and not to belabor on the statistics that I shared earlier. We can see the statistics for TB, and prior to 2021, and these again are just figures and statistics from Kenya National Bureau of Statistics, who are the official government statistics body, and also the World Bank and World Health Organization. So you can see some of the numbers that are coming in for Kenya. And, over the 120,000 people develop TB annually. And we are seeing the large percentages for children, the double digits for children. And in 2020, that is just 2-3 years ago, TB accounted for 3.2% of all deaths in Kenya. So we can see the severity of this of TB, more so in this country. Some of the key challenges, just combating communicable diseases alongside a rising burden of non-communicable diseases and also injuries, ensuring access to and affordability to these services, which are currently, very costly, regressive, and inadequately available, and of course, improving access to healthcare. So there are a lot of interventions that the government and the private sector or the NGO, the non-governmental organizations are putting in place to ensure that there is improved access to healthcare. So this includes, initiatives such as expanding access to communicable disease care, enhancing, maternal and child essential services like maternal and child health, and also addressing regional and socioeconomic disparities. So if you look at the map of Kenya, we are bordered by about 5 countries, and also at the tip of the southern tip, we have the coastal line of the Indian Ocean. So we can see how the country is and what sort of vulnerabilities that are experienced in terms of TB. Even if you look at the people who live along the border, and the border is not tight; it's a bit porous, so people moving in and out of the country. So those are some of the issues that we found out when we were speaking to experts. Who are the vulnerable populations? So apart from the historical populations who are classified as vulnerables, and we have the marginalized groups, and we have the issue with the prisons. So we have about 60,000 inmates in facilities designed for close to half of that. and this leads to poor sanitation, malnutrition, and also disease outbreaks. There have been a lot of initiatives by the government to decrease the number of inmates in the prisons, either by just releasing some of the prisoners or having measures to actually improve the facilities within the prisons. We also have the financial vulnerability and accessibility challenges, and also we had an opportunity to ask the experts and also the participants in the focus group discussions, who are some of these other vulnerable groups. And the discussions, we unearthed that, we have female sex workers, the gay and queer community, and also we have refugees. I think I talked about the porous nature of our border, and more so on the northern bit, where we have war in Ethiopia and Somalia, and that has led to a large influx of refugees into Kenya. So those are some of the vulnerabilities or vulnerable populations that we are experiencing here in Kenya. This is just an overview. TB does not discriminate, and of course, also when we are talking to the people living with disabilities, they mentioned that even in hospital waiting areas, people, the hospitals are crowded, and this is, an indicator that TB even spreads when they're waiting for services in the hospitals. And then these individuals still find a challenge to isolate themselves as they require assistance with their daily cause. Access to medication for these patients is also not consistently provided by the hospitals. This poses a challenge to them. So essentially they are by themselves, and they really have to figure out how to ensure that they're not having other opportunistic infections, because in addition to currently they already have TB. So if they're not taking care of themselves, then this really makes the situation even worse. When we asked the discussants and participants who among them who is considered vulnerable among the Kenyan population, so we have the informal miners. So these are the guys who actually mine using their hand and just locally implemented tools. So we find that these are very vulnerable groups, and mostly this is on the western part of Kenya. Men of economically productive age also mentioned that vulnerable. They're constantly looking of ways to make money, regardless of the condition. We have the truckers who ply all the way from the Kenyan coast in Mombasa, which is just at the shore of Indian Ocean. Some of them go as far as Democratic Republic of Congo, which is on the Atlantic, on the other side of the continent. So these stopovers makes them very, very vulnerable. Interacting with people across 6 or so countries that they track their goods, from the Kenyan coast into the other part of Africa, the central part of Africa. Then I talked about adolescents and young persons, as well as children, those living near border points. We have fishermen who crisscross countries and counties, women in informal settlements, the internally displaced persons. We have the pregnant women, and I talked about the men in productive ages, the elderly, and also caregivers and visitors of individuals with TB. So these are some of the groups of populations who are classified as vulnerable, and we will also, look at ways of what sort of interventions can be put in place to ensure that they're able to contain the infection which they already have. So these are some of the verbatims that were coming in from the key informant interviews. I talked about the mining population as being vulnerable, and why they do not have a workplace for infection prevention and control. So these most as far as TB is concerned, they work in very deplorable conditions. Many of them don't have health insurance. They don't have the, if they become sick, they're essentially just waiting to die, or they'll just be put under the basic medication, which will not really assist them when, for instance, they have TB in that matter. And of course, you find that maybe the fishermen or the mining community, they are mining in Kenya, and most of them are in the western part, and they have this also when they've already mined their minerals, they sell them to, across the borders through illegal routes. So those are also chances that, they could actually spread TB among the populations that they live in. We talked about, the men across the border. Men just across the board, they're considered vulnerable because of their health-seeking behavior. And, the fact that they're constantly looking for ways to make money and, of course, take care of their families. If you look at the gender and age, these vulnerabilities of specific populations in Kenya, are notably amplified by gender and age. So we talked about the young people, who are, the most affected. These are the ages between 24 and 35. So they're just through with their tertiary education, and they're really looking out to make a living and take care of their families. So these are some of the gender and age factors that come into play when we look at the TB population, or those affected by it. So we had a number of verbatins, and I think I will share this for the team to just look at what was being mentioned by some of the experts who interviewed, and also the discussants in the focus group discussions. Looking at some of the, sorry about that, engagement plans. So some of the issues were the political goodwill. So we have the National Council of People Living with Disabilities, which has supported the work that is being done by Stop TB Kenya. And they have an information desk and linkages, and of course provided Stop TB Kenya with county offices for data collection. And these went as far as the community level. At the start of the project, we had, we identified the persons living with disabilities here in Kenya, recruited these people into our study panel, and also had an opportunity to map them across the various organizations who they work with at the community level. And if you look at engagement of these PWDs, one person living with the hearing impairment from TB treatment-related complications has been identified as a champion of persons with disabilities. And, he has also been engaged at the international level. So if you look at these are some of the interventions that we are doing at Stop TB, just to ensure that, people are aware of TB. And this is just a recent media engagement activity, which highlighted the challenges faced by a person living with disability. And this is the story of Joseph, who is 57 years old, hailing from Meru County, which is just at the central part of Kenya. So Joseph has been living with HIV for 19 years. He consequently developed TB and then had loss of hearing. So Joseph's story is a story of courage and endurance. And, instead of sulking and going behind the scenes just to, to complain about his situation, he went into poultry business and, constantly had, fought to make a living for his family. And this has ensured that he has a source of income and hasn't had, a chance or an opportunity to have other infections, looking at where he is. So he has HIV coupled with other disabilities. And I think these stories of courage give a confidence and hope to the people living with a TB here in Kenya. So these are some of the media engagement activities that we are doing at Stop TB Kenya to share these stories and how people are living with, people living with TB are able to surmount some of the challenges that they encounter. Looking at the performance of the COVID-19 and the PPR national response, Kenya leveraged its existing national vaccination structure to streamline the process. So the government really came in to ensure that communication and collateral about vaccination and issues to the TB management properly disseminated up to the community level. And then despite the emergency nature of COVID-19, aligning with the established frameworks which were provided by the government. There was a well-executed vaccination campaign strategy across the country. So there are some of the challenges and the issues to do with the stigma and apathy toward the COVID vaccination, and also the screening activities. So yeah, this has died down over the past few months because of course TB was declared as not COVID-19 was declared as not dangerous anymore. But then again, the interventions that the government took or employed at the onset really helped a lot of people get vaccinated against COVID-19, and by extension, those who are also managing, had TB and were managing the TB situation. Looking at the performance of this national response, so the Ministry of Health took a leading role, as I mentioned before, and this also included private sector, faith-based organizations, just to ensure that there was a comprehensive response, and there was a tailored approach to prevent unnecessary overlap of symptoms between TB and COVID-19. So these overlap of symptoms really ensure that the government was on top of its activities to ensure that there was a clear distinction between TB and COVID-19 and how the population could really manage these. The discussants, mentioned that the arrival of COVID-19 brought a lot of challenges, and they also highlighted the importance of community engagement and thoughtful approach to the pandemic response. At the country level partnerships, so there was a lot of partnerships which Stop TB took with the different stakeholders. Issues to do with even the Kenya Union of the Blind, the partnership that we took with the Kenya Union of the Blind, and we worked diligently to generate a proposal that got recognition, and we got a grant through the Challenge Facility for Civil Society, generously funded by Stop TB. And these are some of the milestones that we ensure to also not only work with the blind and also other people living with disabilities. What are some of the lessons? So these are some of the lessons that we got from the study. The community engagement plans are critical since it provides them with the clarity on the, where do they get their medication? Are they really aware about TB and also vaccines? What sort of support do they require? And, the fact that they have forgotten, how can they be involved in this? And Kenya has a policy for people living with disabilities, and even these are recognized in the constitution, where inclusivity is provided, but it has not been implemented in health response and pandemic preparedness. So these are some of the initiatives that we are continuously doing at Stop TB to ensure that even the government at the policy level are really able to implement some of these policies which touch on people with disabilities. What are some of the achievements we've had so far? So we talk about the partnerships and collaborations that we've had, the support we are receiving from the national government through the National Council of People Living with Disabilities. We've had a lot of community sensitization and last mile approach. This is the CBOs such as Blessed Hidden Wings and Vision Center for the Disabled in Kenya, who played a pivotal role in extending COVID-19 awareness campaigns to these last mile populations here in Nairobi. We also had the digital outreach advancements, and these just looked at it from the digital angle to ensure that there is a viable pathway to engage with the youth, mostly who are in the digital space, and also most of them residing in the last mile policy in the last mile communities. Some of the challenges we had: communication challenges with the people living with disabilities. The issue of mapping. So mapping presented its own set of difficulties because many people with disabilities often go unrecognized and face the stigma of the society. So mapping them became a challenge. Some of the obstacles with the bureaucracies. So reaching out these last mile populations was compounded by bureaucratic hurdles, which have also hindered this process of accessing local political representatives. For instance, the members of county assembly and even the members of parliament. So a significant knowledge capacity gap exists among these last mile populations due to insufficient funding support. So these are some of the efforts, to include these key and vulnerable populations in these platforms. And we quickly looked at some of the efforts that can be undertaken to include the key and vulnerable populations in pandemic preparedness. And some possible recommendations as I wind up. The survey findings underscore substantial progress in engaging these KVPs in pandemic preparedness response initiatives. And then some of the challenges that we have highlighted and still persist. And we will continuously look to address some of these hurdles and strengthen the involvement of the KVPs in the pandemic preparedness and response initiatives. These are some of the recommendations that we came up with. So look at the communication, capacity building, resource allocation, collaboration and alliances, advocacy for policy change. This is largely with the main government, the national government, outreach initiatives, and some of the proposed activities for engagement plans. So we have the leadership training, community workshops, social media campaigns to target the young people, community engagement forums, virtual learning seminars, also to target mostly the young people who are being affected by TB. We have essential resource disbursement campaigns, focus group dialogues, just to continue holding sessions with these KVPs, pandemic preparedness drills. This ensures that we are collaborating with the local health departments and also NGOs to conduct pandemic preparedness drills, so that in the case that we have a pandemic in future, then these people living with disabilities have an idea of what to do and how to manage their conditions. We have ongoing community assessments and also specific liaison appointments, within the healthcare agencies. So those are some of the findings, and just to conclude, and of course looking at some of the possible recommendations that we had, and I think I'll stop there for any questions from the team. Thank you.
Thank you, Charles, for that very comprehensive discussion of both the processes of assessing the vulnerabilities of your identified last mile populations, as well as the specific strategies that you've already started implementing. It's very important that it's, for me at least, to identify how the different health vulnerabilities, specifically disability, affects the already vulnerable conditions of some of the populations. We have some questions already for the discussion in the group chat. The first one was from Jeff. He asked that there's a common finding that the key vulnerable populations and the last mile populations that you have been working with seems to have poor knowledge about both tuberculosis and about the pandemic. This question was if you think there is a shared trauma that makes us forget about the pandemic. And maybe a more important question is, given that we're working on KVPs and LMPs and how these populations are more vulnerable to effects of the pandemics on their health, what do you think will be our role to address this shared common trauma and I guess forgetfulness about the condition? Yes, Jeff.
And perhaps to add also, Jay, that while this CELG project is quite limited in terms of timeline, in our experience in Indonesia and also in Cambodia, was that also in the Philippines as well, as presented by Florita, that this is the first time that this specific last mile populations have been engaged in a health-related phase. And it takes time for them to really understand the health aspect of their, of the issues that they're facing. For instance, in Indonesia, the discussions when we developed the community engagement plans were really around inclusion of social protection and related packages for ex-prisoners. The discussion in health was really even towards the end of that meeting. So I think one of the lessons that we learned is for these populations to really give them more time to understand the issue, while at the same time building their capacity to participate in the governance aspect of it. Thanks.
We have other are there other insights or responses to the question? Just to build on it, I guess one factor that makes the KVPs and the LMPs more vulnerable is their baseline lack of access to information and basically any resource related to health. From my experience with working with TODAs in the municipality where I work, most of them are not aware that the one key benefit from organizing themselves as or for those who don't know, TODAs are tricycle operators and drivers. Tricycles are basically motorcycles with sidecars, which people access or ride to go from one place to another. It's a public utility vehicle in the Philippines. And one of the things that these TODAs or organized groups don't know is that they can use their organized status as a form of leverage to access different services and that provide for their rights. So I guess one reason for that is that these vulnerable groups don't even know that they have the rights that they can ask for from the government. That's why they don't even know that they're some of their groups are affected by tuberculosis. Some of them have the right to organize and then make the organization as an avenue for them to ask for services that should be available to them in the first place. Olive, you were saying something on the chat box, and so was Onesmus.
Yes,
Olive,
yes. Thank you so much, Jerry. Put on my video because I'm not in a good, well-lighted place. My comment, Jeff has just said that if companies don't have information specifically around health issues, and also that they go through a lot of stigma, discrimination, that already, and then they also don't have information, then the ability for them to engage these PPR governance structures are there is very limited because they don't have that information. They don't have, the means. They are not empowered. So this is now done better at level, to ensure that we're bringing on key vulnerable populations that have been left out through all these years to be part and parcel of this the innovation so it's question the team that is here, what innovative things can be done in terms of leave anyone behind, especially in this era where we have TB KVPs that don't even have information about their rights to health, and we can't even expect them to be part of PPR governance structures, but yet we are there. I'll bounce it back to the whole team. Yeah. What should be done? Back over to you, Jerry.
Yeah. So I was wondering, our discussions have focused on. Actually, Jeff, you can go and respond first.
Just to respond to Olive, I think that the question at this point, because number one, this is just my assumption based on the observation, we have this collective trauma from COVID-19. Somehow our experience, we've forgotten everything that has happened for the past 2 to 3 years since 2020, as if COVID didn't happen. And then on the other hand, we're engaging with new populations whom have never been engaged in any health-related aspects, let alone health governance, unlike HIV or TB survivors and TB-affected populations that we know of. I think rather than asking for what are innovative approaches, I think it's a question. It's an invitation for us to go back to the basics of what we're doing in terms of social mobilization. We've heard from Kenya and also in Mozambique in the presentation to really go back to the outreach of informing people what TB is, as an entry point to what pandemic is, and how the two are linked with each other. That when we say pandemic, we're not dealing with a totally new disease. We're dealing with existing diseases like tuberculosis and also COVID at the same time. There's an invitation for us to really go back to the basics of community organization, community organizing, and social mobilization as well. And I think for the Global Fund, this is also quite interesting, given that the new Global Fund strategy is just starting, the Grant Cycle 7 is just starting, and many organizations will be invited to participate in the process. And one of the things that civil society and communities have been asking Global Fund, especially the grants at the country level, is to support the mobilization aspect, of which many of these country grants are saying we don't need to support these different workshops or these different information sessions. But we see all across the 8 countries, the need to really go back to the basic information dissemination, the IAC of TB and pandemics at the same time. So I think we really have to break it into pieces and really go back to the orientation information. So yeah, thanks.
Yeah, that makes a lot of sense. Which is an important lesson that I think that we have already documented, or at least intergovernmental agencies have already documented, that when we strengthen the basic services, and even if we don't focus on pandemic preparedness itself, we are already pandemic proofing a health system. But the main question is, are we focusing, or are we able to focus on improving the health system in the first place, including the basic knowledge of these key vulnerable populations? Are there other concerns or questions? And I guess the question is, given that there is sort of a collective insomnia, or no, collective amnesia about the pandemic from at least the key vulnerable population and the groups, and even in some global south government, what will be the role of the CSOs? And I guess question for the Global Fund is, the organization has given funding to ensure that, or at least to start capacitating key vulnerable populations to participate in platforms for pandemic governance. But the question is, are there organizations or agencies, including the Global Fund, that work with national governments to ensure that while on the ground we're working on the ground to help the KVPs and LMPs, are there strategies, or are there efforts to work with national governments to ensure that there are platforms for these KVPs in case they decide to engage with the government, especially that national government should be the lead in pandemic preparedness and governance?
Yeah, I'm trying to raise my hand, but it's like I'm not getting the icon right. I hope I can speak.
Yeah, you can.
Oh, thank you. My name is Onesimus.
Hello, Onesimus.
Yeah. Following on that question on how communities can actually actively engage in the PPR conversations, I think there is a general feeling of letting the guard down after COVID was declared not as a pandemic anymore. Many of the structures that had been formed, and I know in the Global South, we had quite a number of joint planning committees that included both communities, civil society, governments. Actually, these structures kind of collapse like a vacuum. So you can see people have regressed to their small individual cocoons of I'm just focusing on this small perspective, and leaving the bigger discussion again to be taken over by public institutions, or the governments are actually leading these conversations again. So I think there is need not to let the guard down, strengthen further the institutions that had actually been built during COVID-19, as we are looking forward for pandemic preparedness, to ensure that communities are part and parcel of this conversation all through. Thank you.
Thank you. I completely I agree with that, Onesimus. that we should not let our guard down. So since this is the last session, I think I'll just prepare a short synthesis of what happened, including this session. Wait, you want to add something else, Jeff?
There's a question from Chantorn on the chat
Can
box.
you? Okay.
He said, like, I have a question to ask our team, especially Olive, how to ensure the LMP is part of or integrate as part of the KVP for the National TB Response, which is the framework of CELG. So I think that's a very good question, Chantorn. So I wonder if Olive or maybe anyone at the country level have tried integrating the LMPs as part of the TB key and vulnerable populations as part of the national TB response. That would be, if anyone can share. Yes, Olive, I see you.
Yeah, let me just come in. Thanks, Jeff, and thanks, Chanthron, for that question, which is quite critical because at the end of the day, what we're trying to do is, yes, it's PPR, but before we can even get the KVPs into PPR, they need to first of all get involved with the national TB response. I know Kenya has done very well through this, the CELG initiative, where they've even supported, and I think maybe Charles, maybe you're better able to respond to this question, but I had a discussion with Evelyn where she told me that because of CELG, they've been able to, the Association of the Blind in Kenya have been able to access funding from Stop TB Partnership. And I think there's more that they've done. So maybe let's give that opportunity to Charles to speak more around that.
Yeah. Charles?
Maybe I can respond.
Yes.
Yes, thank you so much, Olive. Yes, as Charles presented, we have been working with the Kenya Union of the Blind. Well, not just Kenya Union of the Blind, like he said, we identified the bodies of persons living with disabilities, but we picked the Kenya Union of the Blind and worked with them in the application process of the Challenge Fund, and they managed to, they got the funding, and we are building the capacities for implementation because it's the first time that they're getting a TB-related grant. So we are building their capacities, we are working with them, and we have also engaged the National TB Program to be able to engage or to start to have strategies of engaging persons living with disabilities, especially the persons, the blind, so that we can have braille materials, for example, for creating awareness. And for the deaf, we're also doing advocacy for their inclusion. And because, for example, they will need interpreters in all meetings, then when you engage them, then you have to cater for their aides or the interpreter. So we are working closely with the NTP to see how can we have policies that support participation of persons living with disability. And we are starting with the persons with living blindness. Thank you.
Thank you. And yeah, because of the time limitations, I think we'll have to wrap up. And yeah, since this is the last session, I just need a short synthesis of all the sessions, including the ones that we discussed here. That's why I was busy writing down some stuff. And we can, I guess we're opening a lot of a can of worms about pandemic preparedness, about our responses to the pandemic and our reactions to the pandemic, and basically how services are not even available. The basic services are not even available, including information and including knowledge, as well as organized capacitating our last mile populations to address the problems that they are prone to having. So as a synthesis, let's just review what happened, and let's see. Let's synthesize the lessons that we have learned so far. So when Jeff offered me the project, or when we were talking about the project, one question was how to integrate the issues of having last mile populations and key vulnerable populations, how to integrate their conditions with the issue of pandemic governance, given that the global north at least is initiating or starting efforts to address preparedness in pandemics, as well, and then relating it to the issue of tuberculosis, HIV, and malaria. So we first so that was the challenge. So when we started with identifying, or at least defining what the pandemic is, and based on the current definition or the proposed definition of the WHO, a pandemic is the global spread of a pathogen or a variant that infects human populations with limited or no immunity through sustained and high transmissibility from person to person, overwhelming health systems. So the key message is that it overwhelms health systems with severe morbidity and high mortality, and it causes social and economic disruptions, all of which require effective national and global collaboration and coordination for its control. We all agreed that the pandemic has caused a disaster in all our countries and all our systems, and that we learned that while pandemics, one of the debates earlier, in our earlier discussions, was whether the pandemic was a disaster. And one conclusion that we have is that not all biological hazards, such as the COVID-19 infection, including pandemics, will turn into disasters. A key factor for a hazard to cause a disaster is the interplay between the vulnerabilities to a threat and the capabilities of a system to prevent and arrest them within a society. With regards to health, the collapse of health and social services and infrastructures to address biological hazards can be considered as having a bigger risk for communities. And in the case of the pandemic, as we saw, while we're having the amnesia, we should not forget that a lot of our systems failed during the start of the pandemic. But we also found that a lot of us are resilient enough, that our health systems are resilient enough. And the WHO defines health system resilience as a health system's ability to prepare for, manage, including absorbing, adopting, and transforming, and learning from a sudden and extreme disturbance, including a pandemic. Some of the lessons learned that we discussed from the second and third lessons include from the pandemic is that there is the need for disaster risk management planning for possible disruptions, including allocating resources and providing mechanisms for reallocation at all levels. The second is the need for institutionalized spaces and platforms for multi-level and multi-sectoral coordination, especially with governments, and the inclusion of vulnerable populations in preparation for and in response to pandemics, to ensure that community responses are aligned with national strategies and the needs of vulnerable groups are integrated in mandates and protocols, as we have seen in the Indonesia report. And from Kenya, wherein the PWDs are integrated, or at least are being engaged in the response to TB. The need for organizational flexibility to adjust program administration and service delivery processes and mechanisms, including those focused on engaging and empowering communities, key vulnerable populations, and last mile populations. Fourth, the need to improve data collection and management to be used as basis for decision-making for policy and program changes, especially during times of crisis and shock. And the last is the need to strengthen the capacities of communities and vulnerable groups to provide basic services and engage in governance of health programs to better handle shocks to the health system in times of crisis. An important thing to note, and I think what we've all been seeing in these discussions, is that one of the key syntheses of the WHO in their Emergency and Disaster Risk Management Framework is that the success of health EDRM relies on joint planning and action by ministries of health and other government ministries, the National Disaster Management Agency, the private sector, communities and community-based organizations assisted by the international community. At the core of effective health EDRM are efforts to strengthen a country's health system with a strong emphasis on community participation and action to build resilience and establish the foundation for effective prevention, preparedness, response, and recovery from all types of hazardous events, including emergencies and disasters. And that, I think, is what's very important about what the CELG project is doing. It's trying to access the last mile populations who should be the benchmark of what the health system should be working for, and how it should work, and what kinds of services should be available to the most vulnerable groups. Because at the core of it, a health system will be pandemic proof if the basic services are available and efficient. And based on the lessons of learned from the COVID-19 pandemic, as evidenced from the WHO documents, a lot of the things that should have been done should have involved a lot the communities and last mile key vulnerable populations, because them being vulnerable makes them more being more vulnerable baseline to the different health diseases like such as TB makes them more vulnerable to the effects of the pandemic. So we discussed about the last mile populations, and it was a very varied group that we discussed. We had PLHIVs, we had persons with disabilities, we had nomadic tribes, conflict displaced communities, internal migrants and refugees. We had persons deprived of liberty and prisoners, garment and construction workers, miners, and public transportation workers. So we saw that the pandemic has different effects on different last mile populations given their different vulnerabilities. But they had several commonalities which we are now facing and which are now discovering, including the following: again, the increased exposure and risk to infectious and communicable diseases, as well as non-communicable diseases, as presented earlier. Lack of access to health services, including information, which Jeff brought up earlier, which raises the question: are we having an amnesia, a collective amnesia about the pandemic? Or maybe my more important question is it possible that it's not that we have amnesia, but it's that baseline you're not aware of our rights to access health and our right to health itself? And then there's limited, particularly for the LMPs, there's more limited representation in health governance decision making. And as we saw, the pandemic is a multiplier of the vulnerability, especially among the last mile populations and key vulnerable populations. So from your studies, from your assessment studies, as well as from the proposals, we found the following key strategies to strengthen KVP and LMP engagement in strengthening and pandemic-proofing health systems. The first common activity is to organize KVPs and LMPs for integration into existing CSO engagement structures. The second is capacity building through pandemic literacy and pandemic governance integration in the organizational process, in addition to basic health literacy, such as in TB literacy. The third is facilitating community-led mobilization, advocacy for increasing engagement and participation platform. Opening platforms for representation and participation in health and pandemic governance structures. And lastly, and I think which is most important when it comes to addressing the needs of last mile populations and vulnerable populations, is to address structural issues and concerns that propagate vulnerabilities, including basic health service accessibility, stigma, income inequality, occupational conditions, conflict, gender relations, accessibility challenges, etc. And I think that's it's very important that we don't just focus on pandemic preparedness, but see pandemic preparedness as just a part, or as an important part of the bigger issue of providing the basic services and ensuring that the rights of the most vulnerable groups in our society have their basic rights and enjoy their quality of life. Because as what the USCDC says, a chain is only as strong as its weakest link. And in terms of pandemics, the last mile populations, and in terms of other diseases, the last mile populations are usually the weakest links because of their vulnerabilities. And as the UNDP defines it, by the last mile, we are referring not only to the poorest of the poor, but also to the people, places, and small enterprise levels that are underserved and excluded, where development needs are greatest and where resources are most scarce. The vulnerable situation of our last mile populations, given that they have the least access to services, I think should be the benchmark of what we should be doing. And I thank you for the opportunity for this, to be able to learn from what is happening to the most vulnerable communities or populations in your countries. And I think the next question is, given that we have these questions about how to help the last mile populations, the next question is, how do we ensure that they are given the opportunity to engage? So with that, I guess I will give the stage or the platform to Olive as the Global Fund representative, or at least Jeff and Rachel as the regional regional network representatives.
Just very quickly before giving to Rachel and then Olive to close, let me share on the chat box the link to our oops, where is it now? The link to our CELG website. So we've launched it in our first in the previous lessons 3 webinar CELG website. This contains all the different reports, the different assessment reports, the tools, and also the community engagement plans. We will be uploading it on our website on a continuous basis. So this may or may not be the last CELG lessons webinar. I know that this is not the last webinar, but please do visit our website regularly so that you can access all the different materials from the 8 countries that we've been supporting and will continue to support as well. That will also include the webinar recording. Thanks. Over to BB Rachel. Do you have anything?
Yeah, all I want to say is it's been a great learning session. I've learned so much from everybody, and it promises to get better on our next stage on the implementation on our follow-up webinars in brackets includes. Yes, thank you.
Thank you, Rachel. And you can learn from you can hear from Olive about the next.
Okay,
The
thank you.
challenges and next steps, I guess. Because this is a separate initiative from Global Fund, Act Africa, and APCAFO.
Yes, thank you so much, Jerry, for your wonderful moderation. And I think it's been a pleasure having you in the last 4 webinars that you've been moderating and taking us through a good understanding of PPR, KVPs, and also, what needs to be done. But also I would like to really, first of all, thank our 2 regional TB networks, ACT Africa and ACT Asia Pacific, for coordinating and managing the community engagement and leadership in pandemic governance, and working together with the country partners. Each of the 8 country partners have done splendidly, very well. It's been a very short period of time, but we've seen very strong assessment reports, and as they are finalizing with their engagement plans, we really look forward to learning and making sure that all these discussions taken into recommendations. We know that for the community engagement and leadership in pandemic governance project has been extended, the implementation period has been extended, and I think ACT Africa and ACT Asia Pacific will notify the country partners. And we are happy to also mention that there's another phase that is coming up shortly. We will also be informing around the next phase, which will start in May and go up to December 2025. So these conversations are just the beginning of what we have been is the beginning, and we hope that all these lessons, all these recommendations, they are opportunities to really strengthen engagement of key and vulnerable populations to participate in decisions that involve them. I would like to say thank you on behalf of my department, the Community Rights and Gender Department within the Global Fund, for all your participation. And this is not the end. Let us continue. We still have the engagement plans to be developed. We still have its implementation, and let's continue sharing case studies. We've done a lot, but this information still remains within just us. So how do we get other people to hear the findings, all this information that we have, so that it just doesn't remain within those of us who are already converted? We need other people to know, other development partners, apart from the Global Fund, to also participate in ensuring communities are engaging when it comes to pandemic preparedness. With that, again, my thanks to you, Jerry. Thanks to ACT Africa, ACT Asia Pacific, country partners, and everyone that participated in these discussions. Asanteni sana, merci beaucoup, gracias.
you, Olive. Jeff and I were talking earlier, and Rachel, we were talking earlier, and there are questions that have been raised and was not discussed earlier because due to time limitations. But I just want to remind that we have a website, the CELG website. We'll be posting it. I think Jeff posted it on the chat, on the group chat. We can continue our discussion there. And before we leave, may I request us to take a picture when you open your videos, the cameras. Are you going to do the screenshot, Jeff, or?
Yeah, I can do it. Let's just wait for everybody to.
Oh, it's nice seeing everyone.
All right, I'll take a photo now. Ready? 1, 2. Another one. Okay, one last. All right.
Thank you, everyone. It's nice to meet you.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
How are you,
Happy
Jeff?
New Year.
Jeff,
Thank you,
happy
everyone. Bye.
Bye.
Hey,
Thank you all.
Evelyn. Happy New Year.
Hi.
Thank you all. Bye-bye.
Long time no see.
Thank you
See
too.
you
Thank you
around.
too. Bye. God bless.
Bye. Okay, let's just wait for everyone to exit.
Mm.